So I will just introduce you and then I will hand it over to you. We'll shut off all of our cameras and I'll point the spotlight at you. So if you see a shift of view.
Sounds good.
All right. Okay, well, we're going to get started. Thank you guys. I hope you've been able to submit all your projects and had a really good, fun hackathon week. We have a really exciting guest, our closing speaker, as a little surprise/prize for you guys. We have Dr. Mark Davis, who is the Chief Medical Officer at IBM and Watson Health for all of Europe, Middle East, and Africa. He has over 20 years of experience as an NHS general practitioner and has a long-standing interest in informatics, health policy, and system redesign, which has led him to work nationally for 15 years in a number of clinical leadership roles. And now I'm going to hand it over to Mark to let him tell us a little bit more about himself and what he does. Hi, Mark.
Hi there. Ria, thank you very much for that kind introduction. I'm going to do my best to present this and hopefully use some slides, and hopefully my dodgy internet in Yorkshire will hold up through the course of the time. My background is a clinician, and for most of my career I've spent my time at the interface between technology, digital capability, and system redesign. So in many ways, the kind of COVID challenge and the COVID events of the last few months have absolutely been kind of at the sweet spot of a lot of the things that we have been talking about in healthcare for many years, and has accelerated a number of conversations that have been going on, but perhaps not as fast as many of us would have liked. It is a real privilege to be able to talk to you guys, because if anything is going to get us out of this deep hole that we are currently in, it is innovation, it is creative thinking, it is user-based design, and bluntly, it is science. So you guys are heroes in applying yourself to this challenge. I absolutely applaud you and what you're doing, and I will be excited to see the outcome of this hackathon. I just before we start, I just want you to bear with me and cast your mind back to the 1st of January 2020. So New Year's Eve, New Year's Day. The clock's just chimed 12. You're thinking with your nearest and dearest, maybe you're at a party, maybe you're having a few drinks, you're having a conversation around the year that's going to follow, and maybe you're thinking about some resolutions, maybe you've got exams coming up in the year. And imagine someone comes up to you and says, I think in 2020, and in fact in a few months' time, there will be a global pandemic of a new virus, previously unknown to science, creating a new disease which is not understood, which will bring global infrastructure, economy, movement, and indeed people's personal lives to a grinding halt. You would think that they were, well, they'd had a few too many drinks to celebrate the new year, I suspect. And yet here we are, and it is incredible what has happened so quickly. In many ways, it is the defining health challenge of our generation. And in many ways, I think what we've seen globally by healthcare have been heroic levels of personal bravery and professionalism and commitment. But equally, it has shone a light on some of the limitations of healthcare, some of the hardwired limitations of how we deliver and plan healthcare. And indeed, it's shone a light on just how interdependent we are as a global community. The interdependency of those dotted lines that we call countries, and the interdependencies across those dotted lines have been brought into stark relief by a virus that understandably doesn't respect national boundaries. Whatever you think about the events recently, there is no way back to a life that we knew in December. There are things that have structurally and irreversibly changed. I have spent the last few months talking about PPE, supply chain, vaccination development, those kind of things, very operational response things to the virus. And I've been given this brilliant opportunity to take a step back and think more strategically about healthcare. So I've been asked to maybe talk for 25 minutes about what COVID might look, what a new version of healthcare might look like, living with COVID, so-called healthcare 2.0. So I'm going to try and share some slides as I talk, and I'm kind of hoping you're looking at a title slide. We'll see. Okay. So the substance of my argument is essentially that healthcare will be characterized in the future by these four things. So I believe it will be more personal, more integrated, more participative, and ultimately more digital. And I say that not because of wishful thinking or a kind of strategic imperative. I actually think it needs to be. For us to be able to restart healthcare and re-establish the services in a sustainable way, we are going to need to adopt and hold fast those four principles, and I'm going to make that argument. The first one is really interesting to me, and there's a photograph of a classic kind of clinical scene, obviously pre-COVID. But despite the fact of the challenges that we've had with personal protective equipment and PPE, this is a photograph of my wife taken yesterday, who's a primary care physician, a family physician in the UK. Quite how you are expected to connect with people and do the emotional and empathic aspects of communication, which are so critical to the delivery of healthcare through that kind of mask, visor, and gowns, is an area of particular challenge. But despite that, I believe healthcare is going to have to be much more personal. So let me just kind of chart you through what we've seen in terms of how healthcare has responded to COVID-19, and I would characterise it in these three boxes. So firstly, the kind of evolving strategic requirements, i.e., what healthcare has needed to do. The second column that you can see there is essentially the science. So as a clinical community, us learning about COVID-19, what it means. And then lastly, around how we start to think of restarting and recovering healthcare performance, and in the UK context, NHS performance, acknowledging that we have a backlog and we have to re-establish services probably in a new way. And two of the principles that I think are really important that underpin this, you can see along the bottom there, that it's all predicated by however the pandemic will further develop. We have seen one wave, but it is almost inevitable we will see further waves as social distancing starts to become relaxed in different parts of the world. And indeed, we are looking at a world where COVID-19 is unlikely to go away. Unless we see a vaccine, which we're unlikely to do within a time span of 18 months, certainly, or a new molecule or an existing molecule is so biologically active that it significantly changes the biological course of the illness of COVID-19. So many people are describing COVID-19 as the new specialty in clinical practice. We are going to have to run the existing healthcare system in parallel to a COVID-19 service. So in many ways, that emergent strategies was in three phases. The first was very clearly around critical care, particularly around ventilated patients. The second was much clearly more focused on the community and particularly care homes. And the third was around preparedness and us starting to think around what we need to put in place as we think about further waves and what subsequently may happen. But if you just think with me for a moment about the challenge of how we might restart healthcare, how we might start to recover, and in the UK context, the NHS, essentially there are three questions we need answers to. We need to understand our variance from normal. We need to understand the nature of the backlog, both in terms of scale, mobility and the distribution across different healthcare settings, whether that's in the community, secondary care, tertiary, indeed end of life. And we need to understand the distribution of mortality and morbidity across COVID and non-COVID cohorts within that population. So having understood that, which is no mean feat, the second is to put together a delivery plan. So this is focused on understanding the risk profiles of individual cohorts within that patient group, which is difficult because if I just remind you, as we all know, this is a new disease and those risk algorithms are emergent. They are being published on a kind of daily basis, but they are new. We need to think around, particularly around capacity, staffing and geography, different ways of delivering care in order for us to get back on our feet. And critically, we need to think about staff welfare and staff mental health. This has been some of the most stressful times for those working in healthcare, in fact, for most of us, in fact. And we need to think about how we look after and maintain the welfare and mental health of these are critically important key workers for something that is a marathon, excuse me, and not a sprint. And the third area is, I'm getting to loathe this expression, the new normal, but I couldn't think of a better way of describing it, but how we shift to sustainable models of delivery that I believe will be better integrated. And what I mean by that is between health and social care, take on new delivery models using virtual consultations, for example, and embrace them as in our usual mode of delivering care. And critically, the impact that all of this has had on broader public health. So I'm thinking the impact on the population of domestic violence, of at-risk children, mental health in the broader population, and critically important, what we are likely to have seen in terms of health inequalities in our society having been made much worse by this disease. Someone particularly naive suggested that COVID-19 was the great leveler. Nothing could be further from the truth. And I think when the advanced analytics comes out around mortality and morbidity of COVID-19, we will see significant differences in distribution across different socioeconomic groupings. So when I talk about new care models, just kind of for the sake of the avoidance of doubt, I am not talking about looking at what we are currently doing and using technology or lean processes or some sort of redesign thing to do it better. I'm talking about a radical reinvention of how we deliver care. So what we've seen to date have been some stabilization activities, the introduction of telehealth, for example, a degree of analytics around risk, predictive risk, some work around extending critical care capacity within our hospitals. We started to see some automation and some digital transformation within organizations. Where we need to get to, and I feel this very strongly, is to take a system-wide approach to reinventing whole care pathways as a way of addressing the end-to-end implications of this condition. As you see on the left there, that touches not only the geography of where care is delivered, indeed what care pathways and interventions were responsible, but actually thinking creatively around our workforce and thinking around who is best placed to deliver these things, thinking creatively around different types of professionals, potentially informal carers, non-statutory segments of society, and critically patients themselves and their families. So I said there were these 4 elements of the shift, and I claimed that it was going to be need to be more personal, and I believe that very strongly for across 2 levels. So healthcare and social care centered around the individual, which uses a patient-centric view and a patient-centric design model, whether that's data or flow or indeed regulation, but putting the patient at the center as an individual in terms of us using that as a design principle to think around how we do user-based design. We have talked about this for many years, and there have been many attempts to do this, but it is now a strategic and operational imperative, because otherwise we will not get ourselves into a place where sustainable healthcare delivery continues. This touches clearly precision medicine. It touches the ability for individuals to take more responsibility for their health, and I think it is inevitable that we will see a shift to more personal responsibility of well-being and health in a broader sense as part of this kind of living with COVID world. I'm fond of saying that the elements of the workforce that we have ignored and made least use of in the history of medicine are indeed patients themselves, which, just to state the obvious, that's actually us as human beings. So that works at the individual level, but actually it works at the population level as well. And if you excuse me just being slightly simplistic for a moment, this is a representation of a focused and targeted design system for healthcare, using baseball as an example. So these kids represent cohorts in the population, and bluntly what we do currently in healthcare in a pre-COVID world is on the left. We do the same thing for everybody broadly. It is a spray and pray, a strategic approach to healthcare delivery, and it leads to very significant differences in outcomes. The outcome here is obviously these 3 kids being able to see the baseball match. Contrast that to an analytical examination of the needs of each one of those cohorts. In this context, it's the height of the children, matched against the resources, the boxes, and coupled with a systematic measurement of outcomes and patient experience, i.e. whether they can see the game, and I guess whether they're enjoying the game. That picture on the right, I think is a world that is inescapable in a COVID environment. We do not have enough resources to do what we've got on the left. And there is a moral and an ethical imperative on us now to use the resources that we've got to maximise the outcomes that we have for particular populations, and I think the time is now to make this the way that we deliver healthcare and an organising principle to thinking around design. This is about putting populations at the centre of healthcare as opposed to organisations, which bluntly is kind of what we currently do. So that's around making it personal. The other thing I said was make it integrated, and I mean this in 2 ways. One is you see this statistic that actually, if you look at healthcare, about 10% of the outcomes of healthcare are dictated by healthcare itself, what doctors and nurses do. The other 90% is dictated by your surroundings, your work, significant relationships, your housing, transport, etc. So if we're serious about improving the outcomes and well-being of the population, we kind of need to think about the other stuff as well. And there are all sorts of implications around that in terms of data analytics and the kind of insights that we would need to drive and nudge behaviours in order to get the kind of outcomes that we want to see. But I also mean it in the kind of health and social care perspective. And certainly in the UK anyway, we have kicked the can politically down the road several times in addressing the challenges of how we adequately resource social care and how we start to integrate it in a much closer operational way with the mainstream delivery of healthcare. And the reality of the mortality that we've seen in care homes in the community, the challenges that we've seen around safeguarding of elderly and vulnerable people within those care homes has absolutely put it up the political agenda. Certainly in the UK it has. I'm sure that's true of other parts of the world as well, in such a way as we have to address how we sustainably fund ongoing care for some of the most older and most vulnerable elements of our society. I was just gonna show you a video, but in the interest of time, well, actually, why not? Let's have a go. So the third one I talked about was around participation, which is related to this issue around people taking more responsibility. And this is a brilliant illustration of that. Some work that we did in IBM Watson Health, which I think demonstrates the point very nicely. So let's see if this works.
Dear Diabetes, since I was 9, you've been a part of me. You have impacted what I eat. You make me track my numbers. You make me, my family, my kids worry. The uncertainty of whether I am making the right decisions about you and my health never leaves. You're unpredictable and leave me guessing. But now, my phone, which I use to know the weather before it hits, get directions, and keep in touch with friends and family, has a new app designed to help people with diabetes like me. With the Sugar IQ Assistant, now I not only have numbers and data on you, but insights into what makes you tick. The Sugar IQ Assistant understands me, my life as a wife and mom with young kids, my passion for exercise, and my commitment to a job I love. And Sugar IQ with Watson technology actually predicts when I could have lows, so I can get ahead of it. With the Sugar IQ Assistant, I am now clearly smarter about you, diabetes. Yours truly, Michelle. Dear Diabetes, since I was...
Don't do it again. So I mean, there are many examples of those kinds of apps, and I really hope that some of the hackathon projects that you've been working on are well-being apps, diabetes or other conditions, which empower and support people to have a very personalised view of their own kind of long-term conditions and indeed their wellness. We cannot afford to continue not doing this and not using people's ability to prevent illness and enable people to stay well. I am going to try and move on to the next slide, but I don't actually know how to do it. The other one I said was participation, and I think there is something really exciting, really interesting going on about a redefinition of the relationship between our communities, our neighbourhoods and healthcare. I think we've seen that all over the world. Chiara is from Northern Italy, and we first saw it in Northern Italy with those amazing scenes of people clapping and serenading key workers and healthcare professionals in Northern Italy when the virus first bit in that part of the world. But we have seen that pattern replicated globally. In the UK, we had 750,000 people want to volunteer and get involved in the COVID-19 response. Unprecedented levels of social capital, which were plugged into. We've seen really moving demonstrations of appreciation and acknowledgement of healthcare, and the label you can see there on the right is the label from my wife's scrubs, and a little note from the children of the local school who actually sewed those scrubs together. And it kind of, it's incredibly moving to see that level of connection of neighbourhoods and communities with healthcare, and that momentum we must not lose, because there is a shift that is possible from seeing populations not as people that consume resource around healthcare and a problem to be solved, but start to see communities as a resource in themselves to help us stay well, to help us remain healthy, to support the most vulnerable elements of our society, and indeed promote wellness. And the last thing I said was around digital, and here's just some examples of the kind of things that we are seeing around digital. One of the problems here is teleconsulting, although very important, has tended to crowd out the debate around many of these other important things. So teleconsulting has been really significant and very fast. We have seen general practice shifting to wholesale adoption of teleconsultation in a matter of weeks. Incredibly, the vast majority of consultations are now virtual in the UK in primary care. But actually, that is an important, but one example of how digital capability can transform and create opportunities for different ways for people engaging in healthcare. And I would cite the implications to our hospitals of infection control. So we will need to see a reduction in the number of beds in our hospitals because of the requirements of spacing. As a consequence, we are going to need to see a situation where people are traveling less to hospitals. So a shift towards diagnostic services in the community, a shift towards diagnostic services direct to the consumer, a world where we are using the Internet of Things, and we're using wearable devices, and we are using the opportunities potentially of 5G and other connectivity technology to monitor people in their homes. And of course, we're using the very significant opportunities around artificial intelligence and analytics and automation to kind of augment clinicians and support people to make sure they get the best outcomes and the safest outcomes for different kinds of care pathways. So a really exciting time, happening really fast, and we must absolutely use this opportunity. We've already seen a step change in attitudes of digital adoption across different parts of the world, and that is a momentum that we should not let go. We shouldn't make sure we don't slip back into a previous way of thinking, and I am very confident that this is we'll look back on this as a sea change moment for the digitalization of healthcare and care. And here's a simple example that we were doing in the Middle East, which was around thinking about patient flow accelerators. So using apps someone's going to the hospital, using your phone for wayfinding, using it for virtual checking in, using it for pre-clerking, if you like, doing symptom checking and taking a history on your phone prior to seeing a doctor, using it to check your sentiments, how you're feeling, and indeed using your phone to embed culturally sensitive information support about the consultation that you've had. I mean, this kind of thing completely revolutionizes the experience that people have of engaging with healthcare, and very much makes them equal participants rather than passive recipients. The last thing I will say is just for a minute, just reflect on the very significant opportunities that we have around user-centered design. This is a time to put patients and populations at the center of our design thinking, indeed with clinicians, and use the principles of user-based design for us to rethink the opportunities and reimagine the ways that we deliver care. I think it's a very important moment in history, and I think it's incumbent on all of us who work in the arena to drive and help ensure that we see this change embedded in the future, as indeed you all have been in the work that you've been doing on hackathon, and I repeat my congratulations and my thanks with this great quote. I'm a brilliant Woody Allen fan. I'm interested in the future because it's where I'm going to spend the rest of my life. I think we can all relate to that. And I look forward to the conversation and maybe some questions that you might have for me. So thank you.
Amazing. Thank you so much, Mark. That was very insightful. It's good to know that, you know, our future is promising and there's still ways that we can develop. So yes, if you'd like to submit a question, please use the Q&A box, and then we'll try to get your questions answered. But I can start off with some questions if that works for you. Yeah? Okay. I'm going to take that as a yes. What kind of new tools can help employers support workforce health and readiness post the COVID pandemic? I noticed you did talk a lot about technology, and there's a lot of contact tracing apps, but do you think they'll work? Can we get back to a new normal with them?
Yeah, so I think that's fascinating. I have the privilege of chairing a network of chief medical officers, which is what I was doing this morning, actually, who are chief medical officers of kind of large companies across the world, like airlines, mining companies, car manufacturers, and financial services companies. And they're all grappling with the issues around, you know, how we, you know, having locked everything down now, how we move to new ways of working. And in some industries, that's about return to works, like the airline industry. They currently have very significant challenges because anything they do in the airlines has to be standardized across the world. And we know how difficult that is. So in a world where, for example, you need 14-day quarantine periods for flying into a different country, that just about kills off international travel. So unless we have some reliable way of testing and authenticating a result, you know, in that particular industry will find it really difficult to get started. In other industries, it's more about how you return to work. Return to the workplace rather than return to work, because they've got people who are working, they just have like this, they're working virtually, but how we get them safely back to either a part-time or a full-time capacity back to the office for when face-to-face meetings are important. It is inevitable, I think, that we will take a risk-based approach to that. So we will look at individuals' risk, and you asked about technology, so analytics that individually calculate your risk of becoming infected, or the implications of being infected will have to be borne in mind when people are going back to the workplace. we are doing a lot of work around blockchain to produce kind of authenticated and reliable ways of associating some sort of test with an individual. Now, we're doing that because we think it's going to be really important, and it's going to be a significant data point to contribute to that risk-based model of return to care. However, as you know, because we were talking about it, the science kind of hasn't caught up yet. So you know, when looking at, you know, antibody responses to COVID-19, we don't know how significant that immunity is going to be. We don't know how long it's going to last. We aren't really very clear about the relationship between our serological testing and the clinical and risk-based implications of that. We hope that better tests emerge. We hope either PCR RNA testing or indeed long-term immunity testing, IgG, but actually in the fullness of time, we may hopefully see a vaccine, and we will need to be able to prove that people have had a vaccine in a reliable way. So I think the answer to your, that was a long answer to your questions, but so I think the analytics, the risk-based analytics, critical bit of technology. I think the blockchain authentication is going to be a really important part of certification and proving results. And the third element isn't really a technology, but is a health and well-being framework that companies will adopt in ensuring that people are able to stay fit, healthy, you know, high levels of kind of emotional first aid and emotional well-being that are applicable to people working in their home or perhaps only occasionally coming into the office. Now that's an emergent discipline, and there's a lot of work going on thinking about how we embed that into the kind of duty of care that companies have to their employees.
Amazing, thank you. So we have a few questions from the audience. You talked a lot about the move to diagnostics online. Do you think this will change the attitude towards public and private ways of administrating healthcare? For example, the NHS versus the American system?
So that's a really interesting question. I mean, in principle, one of the things that we have seen recently in healthcare is the ruthless application of standards. So what I mean by that is messaging standards, record standards, and digital standards. And if you implement those standards in a way where devices are interoperable and there is free movement of information and data, it kind of doesn't matter where it comes from. And that's the point. It creates a much more diverse and, if you like, inclusive way of people contributing to a healthcare record so they can get their results or their blood tests in whatever way they want to. I wouldn't characterize it as publicly funded versus privately funded, but I would describe it as being less monolithic and more diverse, and something that is more controlled by the citizen and less controlled by, you know, an organization, a hospital, or a GP practice. If there is any opportunity that we have in the world that we're currently in, it's the opportunity to make a frictionless interface between a citizen and the healthcare system. And those standards and that inclusive way of being able to receive data and results from different sources is a key part of that frictionless journey.
Amazing. So another one of our questions is, given that the pandemic caused a sudden and large-scale adoption of health technology, what has been the biggest problem? Digital transformation, especially in public systems, was traditionally slow. Was that to avoid risks?
Whoa. So So look, healthcare is one of the most highly regulated industries in the world, for good reason, because when we make mistakes, we can kill people. So we have been very conservative adopters of technology, and been very cautious. And I have to say my profession has played a part in that conservative thinking. My profession is not one that is characterized by embracing innovation and new ways of thinking. I can say that. I've been a doctor for 25 years, but those two things are not the main reason. Actually, I don't believe. I think both of those reasons are they're important, they're significant, but they're not the biggest issue. The biggest issue, I believe, and this is a personal perspective, is what I would call system alignment. So we have attempted to introduce a bit of technology, and it's often cut across the way we pay for things, the way we reward professionals, the way we regulate things, the way we organize patient flows, and then incorporating those devices or whatever into the workflow has been incredibly difficult, and adoption has been really hard, and the change management aspect of it has really held us back. The interesting thing that's happened with COVID is we've had a single pressing change imperative, and that is infection control, to protect patients from healthcare professionals and to protect healthcare professionals from patients and the transmission of COVID-19. And that single change imperative, that system alignment, has driven a whole raft of digital capabilities in the way that I've just described. But I don't want to repeat what I said before. We shouldn't constrain our thinking into just teleconsultation. It goes much more systematic than that, and such as to touch on, how we deliver and care in all sorts of ways.
Great. A lot of questions about the private versus public sector. You talked a little bit about blockchain and data analytics. So what role can AI play in delivering assistance to people post-lockdown?
So really good question. I'm a great believer in AI, standing for augmented intelligence, not artificial intelligence. Anyone who's heard me speak on the subject, I talk about the combination of humans and machines working together, being better. So Jimmy, let me just say at the outset that I don't see this as being a world where in some way AI takes the place of doctors or healthcare professionals. This is around looking at what AI can do really well, and looking at what healthcare professionals can do really well, and bringing those things together. Because bluntly, there are some things in the delivery of healthcare for people in lockdown that are always and will always be analog. Communication, empathy, those things, emotions, human to human emotion and communication. And we would want it to be so. But there are things that machines are really good at. So artificial intelligence is brilliant at processing large bodies of knowledge, of analysing blocks of clinical records, bringing those things together and making contextually relevant decision support at the point of care to augment clinical decision making, to make it more consistent and safe. And I think there are major opportunities in introducing AI into a care process for people who are locked down, in terms of imaging, in terms of risk stratification for the risk of admission or other areas. I think some of the interesting things, not from a healthcare perspective, from a citizen perspective, is around how natural language processing aspects of AI can start to rethink how we engage with healthcare institutions. So we are well used to using virtual assistants, chatbots, for us to speak to the bank or the insurance company or whatever, and then we try and have contact with healthcare, and all of a sudden, it has to be between 9 o'clock and 11 o'clock when the receptionist is working and it all finishes up, whatever time. It doesn't need to be like that. And certainly in IBM, we've been working with a number of hospitals, not the kind of places you might expect, actually. Children's hospitals, cancer hospitals, hospitals dealing with people who are visually impaired or blind, and incorporating visual assistants into as it were, the digital front door of the hospital, allowing people to have a much richer experience and a more personal and flexible experience for them to access information and support from an institution, which I think is really, really significant. So I've talked about care, how it changed care. I've talked about how it can change access. And I think the third one is one there isn't talked about very much, actually, but it's around the kind of back office functions of medicine and healthcare, which have an awful lot in common with retail and supply chain thinking and other industries, manufacturing and otherwise. And they are, decades behind what we do what we enjoy in other industries. So, and these things have an enormous impact on the experience that citizens have of healthcare. So I think there's enormous potential for robotics, process automation and artificial intelligence to optimize those back office supply chain functions, whether that be appointment booking or device delivery or drug administration, in a way that I think has been well tested by other industries, so it would be very easy for us to adopt in the healthcare setting. If I could just be contentious for 1 minute, one of the things that has happened in the UK with the recent crisis is it's demonstrated some of the cracks that we have in the UK NHS in our very federated way that we plan, say, supply chain. So we let organisations do their own thing, and then when it was stressed because of either access to ventilators or PPE, that very federated model really struggled, and it was a real challenge for us. Had we had a more centralised and bluntly a more modern supply chain management system, as would be enjoyed by other industries, we potentially could have avoided many of those challenges.
Very interesting. Interesting to know. I know we have a lot of participants who are AI majors and working on their healthcare solution for us. So maybe we'll share some of those with you afterwards. So I'm just going to wrap up, but is there any last final words you have for our audience? Any tips, any recommendations?
Any tips or recommendations? So I'm going to say something quite naff, but I actually believe it. So Winston Churchill had this famous quote, didn't he, during the war around never in the history of human conflict has so much been offered by has been owed by so many to so few. And I think the same is true of the war that we are currently waging against COVID-19. And the few that we will owe a debt to is you guys. It's the innovators. It is those who have the courage to think outside the box and create new ways and challenging, disruptive ways of allowing us to rethink both healthcare and well-being. And you are an absolutely essential part of how we move on to the next phase of humanity. So you are the few that all of us will be indebted to. So I congratulate you.
Thank you. I think those are perfect words to leave off on. Thank you so much, Mark, for joining us today. Your talk has been great, very insightful. Thank you again. I'm sure you're busy and would like to move on to better things. We do have another meeting after this, a goodbye and closing ceremony, which you're welcome to join us if you wish. If not, we will speak another time. Thank
Very good. Thank you very much for the opportunity.
you so much, Mark. Have a
so much,
great day.
Mark.
Bye.